Hello everybody, this is Dr. Chris Ferrigno. We're going to be talking about the leg and the foot. Keep in mind when we mention the word leg, we're really talking about below the knee and to the ankle joint, so in this area. Let's get started. Please take a moment to read through the learning objectives for today. Let's take a moment to review some of the osteology of the leg. I'll point out the structure, and you may want to pause the video, take a second to think about it, and then play the video for the answer. Approximately, there are a few named structures. Can you recall these two? These are the medial and lateral condyles of the tibia. Their uppermost portions make a shelf of sorts. Can you recall the name? So those make up the medial and lateral tibial plateaus. Recall on the lateral condyle there's a named area. What is the name of this structure? It's called Gerdy's tubercle. Now, do you recall what attaches to Gerdy's tubercle? I'll give you a hint. It's a soft tissue structure on the far lateral side. If you said it's the IT band, you would be correct. How about this area? Do you recall what attaches medially here? This is where three tendons, which comprise the pes and serinus, attach. Can you remember which muscles contribute to the pes? Gracilis, sartorius, and semitendinosus. Anteriorly, what structure is this? I think I hit that a little too quick, but yes, that's the tibial tuberosity. What about this structure? What attaches to the head of the fibula? You remember? If you said the biceps femoris attaches there, you'd be correct. Also, if you said the LCL attaches there, you'd be correct. And there's another structure that we'll see today called the fibularis longus that attaches to the fibular head. Distally, there are two bony prominences here and here. Can you recall those structures? They help to form the mortise of the talocrural joint. Yes, those are the lateral and medial malleoli. Several tendons and a neurovascular bundle from the posterior compartment of the leg course around the medial malleoli, and they go into the sole of the foot. Two new structures are the interosseous membrane and the soleal line. The soleal line is the site of attachment of the soleus muscle of the calf. And the interosseous membrane is very strong and robust and helps to keep the tibia and fibula in close proximity to each other. It separates the anterior and posterior compartments of the leg, and it assists the tibiofemoral ligaments in maintaining the ankle mortise seen down here. There are three compartments in the leg, and each are innervated by a single nerve. As a review, recall that in the upper limb there are two compartments in both the arm and the forearm. There's an anterior and a posterior in the arm, and an anterior and posterior in the forearm. While in the lower limb, there are 3 compartments in both the thigh and the leg. So the thigh has 3 and the leg has 3 compartments. The anterior compartment has 4 muscles. We typically will say it's a 3+ scenario because sometimes 1 is variable. The anterior compartment is innervated by the deep fibular nerve, and its blood supply is from the anterior tibial artery. The posterior compartment is the largest with 6 muscles that are innervated and supplied by the tibial nerve. So here we have in the posterior compartment, we have the tibial nerve, and its blood supply is by the posterior tibial artery. Lastly, the lateral compartment has 2 muscles, and it's innervated by the superficial fibular nerve, and its primary blood supply is by perforating branches of the fibular artery. Let's recall just how that nerve supply gets down to the leg. The sciatic bundle of nerves, which we saw emanating from the gluteal region inferior to the piriformis, travels down under the cover of the hamstrings. So it's traveling down this way, under the cover of the hamstrings, and approximately this area, but it's quite variable, it splits into the tibial nerve medially and the common fibular nerve laterally. The common fibular nerve will quickly branch and serve the anterior and lateral compartments of the leg, while the tibial nerve will serve the larger posterior compartment. All 3 of these nerves will ultimately travel into the foot. There are 3 main muscles in the anterior compartment of the leg, with the 4th being variably present. The tendons of these muscles cross the talocrural joint and are held in place by this extensor retinaculum. The tibialis anterior muscle and the extensor digitorum longus muscle are more superficial than the extensor hallucis longus muscle, which is difficult to appreciate here in this picture. Note that these muscles extend down past this extensor retinaculum and extend into the foot. The most prominent muscle of the anterior compartment is the tibialis anterior muscle, which attaches from the lateral proximal tibia and the interosseous membrane and extends down to the medial cuneiform and sometimes the base of the first metatarsal in the foot. In addition to dorsiflexing the ankle, it also assists in inversion of the foot. One can easily palpate the tibialis anterior by palpating for the shin, or the spine of the tibia anteriorly, and shifting the fingers just lateral to that spine of the tibia. So here we see that spine, and you just want to shift laterally, and you'll get into the meat of the tibialis anterior muscle. The extensor hallucis longus attaches from the fibula and interosseous membrane and extends to the great toe, of course, to the distal phalanx of the great toe, where it acts to extend that great toe. The extensor digitorum longus muscle extends the lateral 4 toes, and because it crosses the talocrural joint, it helps to dorsiflex the foot. Its muscle belly has a broad attachment along the fibula, the tibia, and deep onto the interosseous membrane. The fibularis tertius muscle is a separated portion of this extensor digitorum longus muscle that inserts onto the base of the 5th metatarsal. It too contributes to dorsiflexion and also acts on the subtalar joint during eversion of the foot. It is absent in about 10% of the population. When the tibialis anterior or tibialis posterior, a muscle we'll see soon, is overused in activities like running and hiking, it can cause micro tears in the muscle and even in the periosteum of the bone. The edema and inflammation that results make the tibialis anterior or posterior very tender. This condition is called shin splints or medial tibial stress syndrome, or MTSS. And of course, if it's a tibialis anterior, it would be an anterior medial tibial stress syndrome, and if it's a posterior, it would be a posterior medial tibial stress syndrome. Recall that the femoral artery passes through the adductor hiatus to become the popliteal artery. The popliteal artery gives rise distally to an anterior and a posterior tibial artery. The anterior tibial artery passes through a gap in the interosseous membrane and courses between the tibialis anterior muscle and the extensor digitorum longus muscle. It supplies the muscles of the anterior compartment of the leg, so we can see that supply in this area. At the talocrural joint, the tibialis anterior changes names to become the dorsalis pedis artery, and this supplies the dorsum of the foot through the arcuate artery. So we can trace that anterior tibial artery down this way. And at that talocrural joint, it changes names into the dorsalis pedis artery, and this dorsalis pedis ends up arching around into the arcuate artery, which we see here. Smaller branches like the deep plantar artery communicate with arteries of the sole of the foot. So here we see that deep plantar artery coming off of the dorsalis pedis artery and extending down between the first and second digits of the foot to communicate with the plantar arterial supply. In lab, you'll find the dorsalis pedis artery just lateral to the extensor hallucis longus tendon. So please note that this is the extensor hallucis longus tendon. We see the dorsalis pedis just lateral. This is quite useful as a landmark in the clinic when you're trying to palpate for the dorsalis pedis artery. So again, the dorsalis pedis artery is just lateral to the extensor hallucis longus tendon. The lateral compartment is rather straightforward. There are two muscles, the fibularis brevis and longus, that both participate in eversion of the foot. That's turning the sole of the foot outward. They both attach to the fibula as we see here, with the longus having a higher attachment and sometimes even extending up towards or very close to the fibular head. It sends its tendon around posterior to the lateral malleolus and through a groove in the cuboid bone, through a groove in the cuboid bone laterally, and then it traverses on the under the plantar surface of the foot to attach onto the base of the first metatarsal and sometimes onto the cuneiform as well, the first cuneiform or medial cuneiform. Because it runs transversely across the sole of the foot, it helps to support the lateral arch of the foot. The tendon of fibularis brevis extends to the tuberosity and attaches onto the tuberosity of the fifth metatarsal. So here we see that attachment there. Violent inversion of the foot may cause an avulsion of the tuberosity of the fifth metatarsal, in which the tendon of the fibularis brevis pulls so strongly eccentrically during inversion, so as the foot is turning inward, you have a contraction of brevis which pulls on the tuberosity of the fifth metatarsal, so hard that it separates from the base of the metatarsal itself. These two muscles are innervated by the superficial fibular nerve, which comes off the common fibular nerve, and is supplied by perforating branches of the fibular artery. Please note that these are perforating branches, and we'll discuss more about that in a minute. On the left is a good example of a plain film radiograph of an avulsion fracture. Note the fractures occurring at the tuberosity itself, where the brevis is attaching. The avulsion fracture is also called a dancer's fracture and occurs when dancers are plantar flex and then they passively invert, calling upon their fibularis brevis to eccentrically control the fast inversion movement. Conversely, a Jones fracture occurs at the junction of the shaft and the base of the fifth metatarsal. So this whole area is the base. This, of course, is the shaft. So we have a fracture between the shaft and the base of that fifth metatarsal. This commonly occurs when landing onto the lateral foot, and sometimes also during dancing or other movements where one is plantar flexed and then that individual loses control and then lands onto this area, thus fracturing it. The common fibular nerve that we saw in the popliteal fossa splitting from the tibial nerve courses around the head of the fibula, specifically inferior to the head of the fibula, and then divides into a deep and superficial branch. So here we see that deep and the superficial branch. The superficial branch innervates the muscles of the lateral compartment and supplies sensory information to the lateral leg and the majority of the dorsum of the foot. So let's take a look at that course. Here we see the cutaneous part of the superficial fibular nerve. It's already innervated fibularis longus and brevis, and it's now innervating the dorsum of the foot, but in specific areas. So here we see that distribution in the green, and then we see the distribution of the deep fibular nerve. So here, going back up, now in blue, we see the deep fibular nerve innervating the muscles of the anterior compartment of the leg and then extending down. We'll have to go over to the next picture here, extending down and innervating specifically the web space between the first and the second toes, plus parts of the toes themselves. So we see this region here as the cutaneous innervation of the deep fibular nerve. Note that if you have the habit of crossing your legs, you can place compression on the common fibular nerve, especially when we characterize that cross-sitting position as the female posture where the legs are tighter, because the lateral leg proximally is pressed up against the contralateral knee. Hence the pins and needles sensation in the lateral leg when it falls asleep. More severe damage to the common fibular nerve causes foot drop, in which the ability to dorsiflex the foot is lost because the deep fibular nerve is knocked out. The fibular artery arises from the posterior tibial artery. Again, we have that popliteal artery extending down, extending into an anterior, and then a posterior tibial artery. And this fibular artery we see comes off of that posterior tibial artery. Even though we have a fibular artery, it doesn't actually course in the lateral compartment of the leg. It courses in the posterior compartment near the fibula and near the lateral compartment. But again, it courses through the posterior compartment and sends perforating branches into the lateral compartment through the intermuscular septum to supply the fibularis longus and brevis muscles in that compartment. The posterior compartment is the largest of the three and is comprised of a superficial and a deep groove. The gastrocnemius is the superficial most muscle of this group, with its two heads attaching to the medial and the lateral condyles of the femur. In other words, this muscle crosses at the knee joint. Contraction of the gastrocnemius produces rapid plantar flexion of the foot needed for running and jumping. So what type of fibers do you think that this muscle is comprised mostly of? It would be of type 2B muscle fibers. Together, the aponeurosis of the gastrocnemius and the soleus tendons form the calcaneal tendon. So note, here we have the tendon for the gastrocnemius. We cannot see the tendon of soleus, but we can make out the soleus muscle here on either side of the tendon. And distally, we'd have a common tendon called the calcaneal or the Achilles tendon. This is the thickest and strongest tendon in the body and attaches to the calcaneal tuberosity. And so we can somewhat make out this calcaneal tuberosity. The subcutaneous calcaneal bursa lies just beneath the skin over the calcaneal tuberosity for smooth gliding during plantar flexion. With the gastrocnemius removed, we can now see the location of its origins off of the femur. The soleus attaches from both the fibula and the soleal line of the tibia and is just deep to the gastrocnemius muscle. So we can make out these origin points here. So note, the soleus does not cross the knee joint, so it doesn't directly affect motion at the knee. Along with the gastrocnemius, it too plantar flexes the foot through the calcaneal tendon. Unlike the gastrocnemius, which is easily fatigable, the soleus is capable of repeatedly contracting over long periods of time. So its muscle fibers are comprised more of type 2A and type 1 muscle fibers. So we use the soleus in normal gait much more than we use the gastrocnemius. Sandwiched between the soleus and the gastrocnemius is the freshman nerve. It is, of course, not a nerve, but rather the plantaris muscle, which we can make out here as a very small muscle belly. This muscle originates off the lateral supracondylar line. So you can see it's a little higher up than the epicondyle. Comes off of that supracondylar line and sends its really long, slender tendon to the calcaneal tuberosity. So we can see that extending more towards the medial side, and it'll come down deep to the general calcaneal tendon, but insert onto that calcaneal tuberosity. It's definitely a weak plantar flexor, and it's considered to be a vestigial muscle, meaning its function is insignificant and is somewhat of a remnant. Despite being robust and strong, the calcaneal tendon can still rupture. Inflammation of the calcaneal tendon constitutes roughly 10 to 15% of running injuries and aggressive sporting injuries, and inflammation results from microscopic tears of collagen fibers in the tendon, causing tendinitis. Calcaneal tendon rupture is often sustained by people with a history of calcaneal tendinitis. After complete rupture of the tendon, passive dorsiflexion is excessive when compared to the normal side, and the person cannot plantar flex strongly against resistance. However, with an intact plantaris muscle, they can plantar flex a little bit. Oddly, occasionally patients with full ruptures report very little pain just moments after rupture. During physical exam, a ruptured calcaneal tendon is broad and flattened compared to the normal side, and also notice the foot is in slight dorsiflexion because the muscles of the anterior compartment are unopposed. In other words, the anterior compartment is pulling the foot into some dorsiflexion, while the posterior compartment is not opposing that into plantar flexion. A simple screening test for a fully ruptured tendon is called a Thompson test. You can see the YouTube link for a demonstration of this test. Treatment includes surgical repair approximating the loose ends of the tendon, or just as successful is a non-surgical approach of serial casting or booting, where the foot is immobilized in progressively increased positions of dorsiflexion. So here's what that looks like. Here's your foot initially in some angle of dorsiflexion / plantar flexion. In case at the beginning, you would have it somewhat plantar flexed, and then a week later you might move them to that position, and then another week later you might move them to that position. That's a little aggressive of an approach, but I think you get the idea. Either way, return to normal gait takes roughly 8 weeks, and normalized gait roughly 12 to 16 weeks. In other words, initially people can walk relatively pain-free and normal in 8 weeks, but for their gait to get completely normalized, in other words, they feel very efficient with their gait and they look relatively normal, that takes 12 to 16 weeks. With the gastrocnemius, soleus, and plantaris being the superficial group in the posterior leg, the deep group consists of 4 muscles, all of which are innervated like the superficial group of muscles by the tibial nerve. So again, tibial nerve innervates all of these muscles in the posterior compartment. The proximal most muscle is the popliteus. So here we see that popliteus muscle. I have this image of the knee joint just to remind you that the tendon of the popliteus right here, this tendon slips underneath or between the LCL, which is here, and the bone itself. The popliteus is responsible for unlocking your knee. Now this can be a little confusing at first. In quiet stance, when your knee is fully extended, your knee is in a very tight, congruent position. In other words, the femur is highly congruent with the tibia. The popliteus, which is roughly in this area, contracts and brings your lateral condyle, pulls your lateral condyle in this direction. What does that do? It laterally rotates your femur with respect to your tibia, thus helping it to unlock, thus then to be able to bend. Taking a closer look into these deep muscles of the posterior compartment, we see the tibialis posterior muscle attaching from the tibia, fibula, and interosseous membrane and extending down just posterior to the medial malleolus and inserting onto the navicular, first, second, and third cuneiforms, and sometimes the cuboid bone. Because of this path that it travels across the arch of the foot, it plays a major role in supporting the arch of the foot. The muscle flexor digitorum longus is adherent to the posterior shaft of the tibia, and like the tibialis posterior, it sends its tendon around the medial malleolus. So the first tendon would be tibialis posterior here. The second tendon would be flexor digitorum longus. And it's on its way to the lateral 4 digits to flex the toes. So here we see that going on to the distal phalanges of those 4 digits. The flexor hallucis longus originates from the posterior shaft of the fibula and courses obliquely across the distal leg. So here we see that fibular origin, and it traverses across the posterior leg, again behind the medial malleolus, but now it's the third tendon that courses behind that medial malleolus, with the first tendon being that tibialis posterior here, the second tendon being the flexor digitorum, and then the third tendon being the flexor hallucis longus. And as its name implies, since it has the word hallucis in it, it's going to go to the great toe. We see that here, and it's going to help to flex the toe. Keep in mind, since all these muscles cross the ankle joint, they can help in plantar flexing the ankle. And because they course medial to the axis of the foot in the frontal plane, medial to this axis here, they're going to be able to invert the foot. So these muscles can invert and generally to plantar flex the foot. Here we can make out the three tendons that we just spoke of in the deep compartment of the leg, coursing around the medial malleolus through what's called the tarsal tunnel, which is formed by the flexor retinaculum that spans from the calcaneus to the medial malleolus. So here we see, I'll just highlight this very lightly, the flexor retinaculum. And here we see it as well with that nice big arrow, blue arrow going through there. So that's what we call the tarsal tunnel, and obviously we have an equivalent in the hand called the carpal tunnel. Within this tunnel, there is a clear relationship and order to the structures passing through, and we use the mnemonic Tom, Dick, and now Harry. Some people will say Tom, Dick, and very nervous Harry, with the V coming in right there. So Tom stands for tibialis posterior. Dick is for the digitorum. A is for the artery. N is for the nerve. If we had a V, that's for the vein. And Harry would be for the hallucis. So here we see this tibialis posterior, flexor digitorum longus. We have the posterior tibial artery. Then we have the tibial vein. And lastly, we have that flexor hallucis longus. Always in that order. It's quite easy to parse out when we're in the laboratory, but it does take a bit of dissecting. This is an area with the with the posterior tibial artery. This is an area where we could catch a pulse. So you could palpate roughly in this area and get a pulse on somebody. Now, we see a lot of things going through here in a relatively small confined area. So you might imagine that we could have a problem here. So like in the hand where we saw 9 tendons going through the carpal tunnel, here we have 3 tendons and some neurovascular structures, and we have that tibial nerve going through there. So that nerve can get irritated, and if that nerve is compressed or irritated in the area, that's a condition called the tarsal tunnel syndrome. Not only does the tibial nerve innervate the entire posterior compartment of the leg, but once it crosses through the tarsal tunnel, it serves the sole of the foot by branching into the medial and lateral plantar nerves, both of which provide motor and sensory to the plantar foot. Note that the medial plantar nerve is more dominant in regards to the cutaneous innervation, while the lateral plantar nerve is more dominant in the motor innervation. Let's review some of the cutaneous innervation of the leg and foot. We'll spend a couple minutes on this, but I suggest that you spend even more time committing this image on the right to memory. So we saw in the medial leg the obturator nerve, and we talked about how the obturator nerve serves the upper medial thigh here. Of course, we saw the lateral femoral cutaneous nerve. We saw that in the posterior abdominal wall, and then we saw it again in the anterior thigh as it came out somewhere in this region, just inferior usually to the ASIS, and it innervates this area of the lateral thigh. So that makes a lot of sense. And then of course we saw branching in the femoral nerve. This branching, here's the femoral nerve coming in, and that branches and serves this whole area of the thigh. So this is the femoral nerve. And then one branch of the femoral nerve comes down in this direction and innervates the medial leg. And that nerve is the saphenous nerve. Well, we saw the common fibular nerve wrapping around the head of the fibula, and in the process, it's going to give off cutaneous branches in this area. Then, the superficial branch, it gives off the superficial branch, which ends up coming down, and if you recall, it kind of splits on the dorsum of the foot to serve the lateral leg. So here we see that lateral leg, and then we see the dorsum of the foot, with the exception of the deep branch coming in and innervating that first web space, or the part of the big toe and part of the second toe and the space between the two toes. Posteriorly, it gets maybe a little more complicated in that we haven't necessarily seen some of these nerves, but we certainly can imagine that the sciatic nerve via the sacral plexus will give off some nerves to innervate the posterior thigh. Again, we see the lateral femoral cutaneous nerve hitting that lateral thigh, and we see, of course, the obturator nerve hitting the medial thigh. And that just about covers the posterior thigh, but then we have the posterior leg and the foot. So once again, we have that common fibular nerve. Remember, it was kind of wrapping right around here, so it's going to give off these branches to innervate the lateral leg. And that saphenous nerve to innervate the medial leg. And if you recall, here we can, well, it's hard to see it on this picture, but that saphenous nerve, if you see on this colored foot, the saphenous nerve is going to get the inside of the foot a little bit as well. We don't see that here. But what we do see here is a sural nerve. So that sural nerve is going to branch off components. So the sural nerve, let's see if we can see that in the back here. Here we have the sural nerve. The sural nerve extends down to innervate the lateral foot and this area back in here, kind of like that lateral heel area. It gets contributions from the common fibular nerve as well as contributions from the tibial nerve. So that sural nerve is typically a combination of contributions from both the tibial and the common fibular nerve. This slide is only here for your reference for your studies. Bunions are very common clinically. The deformity occurs at the first MTP joint here. The condition is also called hallux valgus, or a hallux valgus deformity. A valgus is defined as a displacement of the distal segment pointing away from midline. So here we have the proximal segment, and then we have the distal segment that points away from midline. Note the deformity of the joint complex, including inward rotation of the first metatarsal, which places the sesamoid bones in between the first and second metatarsal head. If the sesamoids get squeezed in there, so does the flexor hallucis brevis tendon. So here we see that flexor hallucis brevis connecting in with those sesamoids. So if those sesamoids rotate in that space, so do the tendons of flexor hallucis brevis. Bunions are often surgically corrected. However, there is a high or relatively high recurrence rate. The plantar aponeurosis is a thickening of deep fascia in the sole of the foot. It is firmly anchored to the medial process of the calcaneal tuberosity and extends forward as a thickened band of connective tissue fibers. The plantar aponeurosis supports the longitudinal arch of the foot. When it becomes inflamed from high impact activities, it causes plantar fasciitis, in which patients present with plantar tenderness, especially posteriorly when the foot is dorsiflexed and the toes are extended. Plantar fasciitis is seen in those who have a change in behavior, particularly when they take on a new sport such as long-distance running, or when they have an occupation which requires them to stand for periods of time that are longer than they are accustomed. Plantar fasciitis presents with pain upon standing after a period of rest. The most common complaint with plantar fasciitis is pain first thing in the morning after standing from the bed. Although it's called deep fascia, the plantar aponeurosis is relatively superficial. Deep to it are 4 layers of intrinsic foot muscles. In the lab, I only want you to ID and know the functions of the muscles of the first 2 layers of the sole of the foot. The abductor hallucis muscle abducts the great toe at the metatarsal phalangeal joint. The flexor digitorum brevis muscle flexes the lateral 4 digits. And the abductor digiti minimi abducts the little toe. Of the 3, only the abductor digiti minimi is innervated by the lateral plantar nerve. So remember, we have the tibial nerve splits into the medial and the lateral plantar nerve, and therefore the abductor digiti minimi gets innervated by that lateral plantar nerve. The second muscle layer in the sole of the foot is associated with the tendons of the flexor digitorum longus muscle. So here's that tendon, and then the tendons as it splits of that flexor digitorum longus muscle. The tendons of the FDL are kept in alignment by the quadratus plantae muscle. So let's outline that quadratus plantae muscle. So there's your quadratus plantae muscle that pulls on the tendon of the flexor digitorum longus muscle, and so it keeps the muscle pulled that way a little bit, which guides the pull of the FDL tendons. It helps the flexor digitorum longus tendon in flexing the lateral toes. Also note we have lumbricals that arise from these tendons, just like in the hand, where we saw the lumbricals arising from the flexor digitorum profundus tendons. Here we have that flexor digitorum longus tendon as the origin of these lumbricals. Just like in the hand, the lumbricals in the foot help to flex the metatarsophalangeal joint and extend the interphalangeal joints. The quadratus plantae muscle is innervated by the lateral plantar nerve. Let's take this tibial nerve, we'll make it split into a medial, and I'll change the color, and we'll make a lateral plantar nerve. And so here, that lateral plantar nerve will innervate the quadratus plantae muscle. You may recall that in the hand, the 4 lumbricals had split innervation, right? We had in the hand, we had the ulnar nerve innervating the 2 medial lumbricals, and we had the median nerve, the 2 lateral lumbricals. Well, in the foot, it's a little different. The lumbricals have a 3-1 split, with the lateral 3 innervated by the lateral plantar nerve. So again, we stay with the orange, and we have this lateral plantar nerve innervating the lateral 3 lumbricals, with the medial plantar nerve innervating that first lumbrical. With respect to the 3rd layer of muscles of the sole of the foot, you should know that the sesamoids under the first metatarsal head are contained within the tendons of the flexor hallucis brevis muscle. We discussed this a little bit when we talked about the halgus valgus / bunion story. We previously saw the blood supply for the dorsum of the foot brought by the anterior tibial artery. As it crosses the talocrural joint here, it turns into the dorsalis pedis artery. Remember that this dorsalis pedis extends down into the foot and gives off this arcuate artery. But at that junction where it gives off the arcuate artery, it also gives off this deep plantar artery, which goes down between the first and second metatarsals. Here on the right side, we pick up that deep plantar artery here, and it helps to form this plantar arch, and it's joining up with the posterior tibial artery as primarily a lateral plantar artery. So this posterior tibial artery extends down towards the lateral side of the foot and connects in with this deep plantar arch that was helped to be formed by this deep plantar artery. Again, just as a review, we had that tibial nerve coming down around the medial malleolus and splitting into a medial plantar nerve and a lateral plantar nerve. Before the split, the tibial nerve gives off some cutaneous distribution into the heel of the foot. And of course, that medial plantar nerve will give off cutaneous distribution medially to the first 3.5 digits, and the lateral plantar nerve laterally to that first, the most lateral fifth digit and half of the fourth digit. Note also that the plantar surface of the foot can be innervated by the saphenous nerve medially and the sural nerve laterally. That concludes this discussion of the leg and the foot. Happy studying.